My name is Iris Udison, and I've been running the World Trade Center program here at Rutgers, sending a lot of my patients to the Cancer Institute. And the last line of my slide here is a slight typo. It should say community outreach meeting, but in any event, we've been seeing World Trade Center patients since 2003. I'm a professor here at Rutgers, here at EOSHI. EOSHI did a lot of things related to 9/11, but one thing that's very clear is one of our current activities that we're doing certainly has to do with cancer in the World Trade Center population. So I'm going to show you on the next slide. Next slide, so good. So these are some of the things that we've done and that we continue to do because we're public health. Identifying the hazard, I've got some slides about that. Identifying the exposed population, understanding all the health effects. We designed a surveillance program. We do a lot of treatment. We do research to understand and hopefully prevent or minimize health effects. We do a lot of community service, and we provide benefits to our patients. Next. These are calculated numbers. Somewhere over 100,000 local workers, community residents were significantly exposed. At least 87,000 rescue workers were on site. We here at Rutgers probably treat somewhere between 5,000 and 6,000 of these workers. Next slide. So this is what was in the cement, in the material, combustion material that our people were exposed to. And notice that asbestos or chrysotile is on this list. It's not the highest thing on the list. Also notice that the initial exposure greater than 100,000 parts per million, meaning that if you have 1,000,000 parts and you had particles for 100,000 of them, it's somewhat of an oversimplification, but that means a tenth of your air was really bad on 9/11 and in the days around 9/11. And next is a map of where the exposures occurred, and you can see that the arrow pointing to the World Trade Center site, but you can see this is New York City, and of course, a lot of the exposures did waft into New Jersey as well. The next slide is exactly what was in our dust, and what's significant about this slide is that the pH of the dusty material was 11.5, basically breaking down the World Trade Center material and allowing not only the irritating particles to come in, but also allowing the carcinogens to come in. Next slide. And this is a slide that actually shows what some of the dust looks like. Next slide. But the unknowns were the most significant and continue to be the most significant, and maybe the gases and other things. Next slide here. We have this slide, which Dr. Leoy, who's not with us anymore, Dr. Wiesel and Georgopoulos did, where they actually analyzed and did an exposure gradient. This is work done here at EOSHI. And what we are very concerned about as we go forward are all these gases which cause many of the long-term problems. Next slide. And a very nice table that we have, which basically shows the combustion products causing cancer, asbestos causing cancer, particles causing airway irritation. So this slew of stuff caused us to make our World Trade Center program, next slide, which originally started to take care of 12,000 people and now is taking care of many more than that, greater than 100. So we started out planning on taking care of 12,000 people in the World Trade Center responder program, and we now take care of 87,000. So that's how many people turned out to be there. And as you can see that we are part of the cohort with Mount Sinai and NYU. Rutgers should be on that slide here. And next slide. So my next few slides, I'm going to go right through quickly, which is how we put our program together. And we wanted to make an accurate registry so that we could have some scientific basis for what we did. And we'll go to the next slide. And we both collect data and we do medical monitoring and treatment on our patients. Next slide. And again, this is what you would do in any kind of environmental and occupational research. Next slide. So we used standardized questionnaires to collect our data. Next. Screening components. These are the things that we did in our actual exams. Next slide. We actually were able to so I said we here at Rutgers see somewhere between 5,000 and 6,000 of these people. All 87,000 people's information is on the diagnostic spirometry, particular criteria that are used so that we can use everyone to be compared to each other. Next slide. So acutely, what did we find acutely? Next. So this is one of our earliest papers here of the 5-year assessment of 9/11 health effects. So at 5 years, on the next slide, you can see that at least 69% of the patients had one respiratory symptom. At least more than half were symptomatic, and this is even 5 years after 9/11. Early exposure being there in the first 4 days correlated with health effects. Now, since we're and this is our spirometry slide, we were able to show that everybody that was there, even if you're perfectly healthy, lost a good 372 mLs of volume. Now, next slide. So when did we first suspect cancer? That should be suspect. I missed that typo here. When did we first suspect cancer in our 9/11 responders? So thinking about cancer and cancer latency, thinking about what the exposures are, potential carcinogenic materials seen include polyaromatic hydrocarbons, asbestos, and radiation. So even in the time close to 9/11, we thought we would be finding hematopoietic malignancies. So on next slide, this is actually a very early slide, but this is what you do. You put together a case series. The first cancers we started noticing, and you could see looking between 2001 and 2007, were multiple myelomas. And we actually published about this, the next slide here. We actually saw here in Rutgers, I saw 2 of these 8 cases here. The good news is one of them is still alive, and he actually goes to Sloan Kettering with his myeloma, and he's had a few bone marrow transplants, but we've been able to keep him alive. But what was interesting to us, even right away, was that we had people under the age of 45 with multiple myeloma. So the moral of the story to people that are listening to this recorded presentation is, if you see something you want to report on it, these 4 patients that are under the age of 45 were all in law enforcement. Why is that important that they were in law enforcement? Is that they really didn't have any other significant cancer-causing exposure other than World Trade. As I said, we found these people, we published on this in 2009, which means that we found it quite some time before that. So go to the next slide here. And we're thinking about the possible etiologies here for our myeloma patients, just hypotheses. Next slide. And next slide is here. Skip that slide, We're going to do that one later on. Multiple illnesses. What did we start finding in 2000 and after we looked at the 10-year anniversary? Next. Okay. Next one after that. Okay, good. 9-year cumulative exposure. So at 9 years, we weren't sure that we had that much cancer yet. We just had some interesting case series. We had a lot of sinus problems, reflux, some things like that. Interesting that we also found, next slide, here in Rutgers, we also found this, and you could see Dr. Sunram is the first author along with me, that we were one of the first studies that found that there were environmental reasons why people developed sleep apnea. So what does that mean for cancer? May or may not mean anything, but what it does mean is that our environmental exposures showed some different diseases than we were used to finding. And on the next slide, what was unique about our patients with sleep apnea was that they weren't big, heavy people. They were regular, average people. And we feel like we were able to show, when we did some other studies that showed that sleep apnea is possibly due to the increased airway inflammation. So these were our early findings. What were we able to show later on? So let's look later on. And first thing is interstitial lung disease on the next slide. We found that that sarcoid, this is New York City Fire Department, that they were able to show 5 times the amount of sarcoidosis and interstitial lung disease in this population. And this was highly significant and continued to go on because we were able to demonstrate this as well in the general responder community. If you can go on, because the fire department is a subset of the responder community. The rest of the responder community is what I said in a previous slide: Mount Sinai, NYU, us, Northwell, and Stony Brook. And let's go on to the next slide. And we were able to show a good amount of sarcoid in the rest of the people, higher in the African American community. So this was our other things that were not cancer. Next slide. So this is now, we're at the 10-year, next slide after this, and now we're at the 10 years after 9/11, and we're starting to think that maybe there is some more cancer. And the first paper that looked at this is the New York City Fire Department. The incident rate is relatively small. Possible increases. This is only at 10 years. The incident rate of 1.010. Possible increase in 10 out of 15 cancers surveyed, including hematopoietic malignancies, thyroid, possibly prostate. So let's go on to the next slide here. And this is the reference for the material that I showed you. And the next slide is our abstract. And looking at some of these numbers, well, thyroid should have an early latency, hence the pretty high SIR. Prostate, the number is not huge, but certainly statistically significant. Hematopoietic and lymphoid cancers. So why is that important? Well, lymphoid cancers, lymphomas especially, non-Hodgkin's lymphomas, have been well documented to occur with exposure to chemicals. Soft tissue cancers, lumping and splitting. So let's go to the next slide here. So we have the New York City Fire Department doing one measurement. The general responders I told you about doing another measurement. The World Trade Center Registry, which is the New York City Health Department, which is looking at both workers there, responders, and people who lived in the area. So if you look at what this registry did, the registry were able to also show increases in prostate cancer. Numbers are even higher there than the previous slide. Thyroid cancer, multiple myeloma. Well, multiple myeloma, the N is only 7, but it's a relatively rare cancer, and they were able to show increases in that. Next slide here. So now we had 3 different cohorts looking at cancer, 3 different kinds of measurements. Granted, we had a lot of men in the responder and the firefighter communities, but overwhelmingly we were able to easily confirm an excess of prostate and thyroid cancers any way we looked at the program. So what did we do in New Jersey here? Next slide. We found, sorry, okay, skip that slide, sorry. Prostate cancer. Okay, now we can go to New Jersey. Next slide. So we found that we had an excess of head and neck cancers. We found that it was biologically plausible, and I'm sorry about the slide that's out of order on the head and neck cancers that I should have presented. We saw 1,500 patients here in New Jersey, and we at the time we got the original idea, we had seen only 4 cases. It turned out that we had more than that after that, but we saw 4 cases, and the expected number of cases in the population, according to Cancer Registry, was something like 23 per 100,000, and we saw 4 in 5,000. So you can see that's a huge number. So this led us to doing further investigations. Next slide. And this slide here, slide here, I'm attributing a few slides to Michelle Mandowski, who probably was, she's one of our graduate students. She was a graduate student, and she did her PhD thesis in this. And we point out the anatomy of the head and neck, and you can see why there would be exposure at World Trade. We noted other risk factors: tobacco and alcohol, of course, HPV, and of course, other occupational exposures. Next slide. And certainly plausible, high intensity exposure, primary route of exposure, cancer causing agents in the dust. And next slide here. And yeah, let's click on all of them. So we've got our larynx cancer. No, go back, yeah, here. So we have all these exposures in our population. We have some that we can control and some that we can't control. Because we saw this, because we saw these head and neck cancers, what do? We aggressively work on reducing the exposures that we can reduce and that we can control. And the other thing that I do is I'm very, very, very likely to refer someone for an ENT evaluation when I know they have the risk factors, when they're complaining about sore throats, when I don't like their dental situation. Next slide here. Um, and so we can do something about cancer. The other thing that, because of the information that we got out of the responder program, we can aggressively get the young people who lived in the area to be mindful of HPV, to take the HPV vaccines, which it's a good vaccine and perhaps prevents head and neck cancers from happening. So that's really important. So where are we today? Next slide. Um, so what I want to point out on this slide is if you look in the beginning, I said we saw mostly asthma and reflux and sleep apnea. Well, lo and behold, we now have more people with cancer, albeit some of them are non-melanoma skin cancers. But you see, we have more people with cancer than we do with asthma now in the program. So I think that's important. I also want to show you that we have them in divided categories: post-traumatic stress, major depression, anxiety. So all of those things are separately presented and not lumped together. So whether there's an interaction between mental health and cancer. Next slide. So as I said, non-melanoma skin cancers, of course, are the highest, but look at the fact that prostate and lymphoma are still so high. Kidney cancer and bladder cancer are up there. And fortunately, my throat cancers aren't that high, but they are there. Next slide. And the community members, wow, there's more prostate that we saw in the community than non-melanoma skin cancers. And lymphoma continues to be high, and kidney and bladder continue to be high. And I want you to notice, that we do have more breast cancer because this is a more female community. And we also have been starting to see more uterine cancers. Uterine cancers weren't originally reported, and now we are starting to see uterine cancers. There's a suggestion of a lot of exposure to endocrine disruptors in the area around 9/11. So that's probably more an issue in the community responders, although we have an awful lot of female police officers with both breast and uterine cancer that we're following in the program. Next slide. This is basically at the end of the talk here. We spend a lot of time trying to reduce risk factors when it's possible, encouraging screening. I spend an ungodly amount of time telling people they need to go for their CAT scans of the lungs or their colonoscopies. I don't have any trouble getting my female patients to go for mammograms. It's a lot easier to get people to go for a mammogram than for virtually any other cancer screening. It's also much easier to get people to go for a mammogram or even the CAT scan than it is to get them to lose weight, eat properly, and exercise. So those are all challenges. I'm happy to know that our Cancer Institute now has people here that can take care of the head and neck cancers. That's a relatively new group of people, Dr. Beninati and some of the other people, and the ENTs here in Rutgers, Dr. Wackham's group, are able to do much more for that. And here in New Jersey, in addition to the 9/11 exposures, we've had some other community cancer exposures that I've been involved with, like in Hudson County, Jersey City, Kearney, we've had a lot of chromium exposures. Interesting is that I have the Elizabeth Fire Department that was also exposed to the chemical control fire in Elizabeth, and I have the Jersey City Police and Fire that also have chromium exposures. So nobody is a nobody has just one exposure in life. Um, but these are the uncontrollable exposures. I can't control who grew up and lived and worked in Jersey City. But if you lived and worked in Jersey City and you have a sore throat, you're getting more scrutiny about everything else you do in life. In our program, I refer a lot of people to CINJ, but I also have a lot of people coming to me from various places in New York, Northern New Jersey. We have great partners in this area. We've got obviously Sloan, we've got NYU and Mount Sinai, we've got Hackensack Meridian. Sometimes I sit there and with my patients and I figure out which place you can actually get to. And that's really important in cancer gatekeeping. You want to go to the place where you're actually going to go to and have care. So we always look at improving access of care, whoever you are, and that's important. And finally, unfortunately, many of our patients do end up needing hospice, but we take care of that for them. We get them whatever benefits we get them. And that ends my presentation. Then
I guess my question is, so I'm actually curious because so I have my mom grew up in Jersey City, and so we actually spent a few years living in Jersey City, and I grew up in Union County. And one of my aunts actually did work very close to the World Trade Center, and so did my father. And my aunt actually passed away from lung cancer about a few years ago, and she had never smoked a day in her life. She
do you know
spent
where
the
in
majority
Jersey
of her,
City? Do you know where in Jersey City she lived?
she grew up, well, she was around the area like near the Heights. So probably by like where I'm trying to think of what the station would be, like near Journal Square.
So the do you know the Newport News condos over there? So my first foray into Hudson County chromium was they found chromium in the soil before the hexavalent chromium before uh, the towers were built, and they had to do a big remediation. But we had workers there that were showing up with abnormal laboratory tests. And we also found chromium exposure in some of the residents of the schools. Now, chromium, hexavalent chromium, uh, classically causes head and neck cancers, but it does also cause or contribute to lung cancers. So I
Mm.
I have a very healthy regard for people that might have had both chromium and world trade, because hex chromium is a serious carcinogen. And so that was my first foray into doing this, was organizing the community response in Jersey City, along with Dr. Gotchfeld, but figuring out how to figure out who was exactly exposed to chromium in that area. She would have had chromium exposure. And considering cancer latencies, I don't know when she got sick, but she probably had the bad stuff in her that she didn't really know anything about. Um, Interesting about chromium in Hudson County is everybody was busy remediating the lead, and then there was chromium in the basement. So they were remediating lead from the first floor of buildings and chromium from the basements.
Interesting. I was just surprised, I guess, because it was like a very sudden thing. And she did, work in the city at the time as well. And she went back to work pretty soon after. But even my own dad was, in the city during 9/11. And a few years later, we've only started to realize that he actually has a lot of lung scarring and issues. Again, has never smoked a day in his life. And now he's gone for a few lung biopsies, and they're not quite sure why, but they're thinking it's because of his exposure when he was in the city during those days. And so I don't know if that was something.
And one of the other issues, since I presented to you about the pulmonary fibrosis, and Dr. Langenfeld's been involved with several of those cases where we've done the biopsy, and sometimes we're lucky and it's fibrosis, and sometimes we're lucky because he actually got rid of a few people's stage 1 lung cancers for me, because we do so much screening in the program, and sometimes we were not so lucky and it was more than stage 1. We just lost somebody pretty recently that was one of your patients that we thought it was stage 1 until it came back and it wasn't stage 1.
Thank you.
So actually, one of my questions was pretty much almost exactly to Gabby's, was have there been studies on not necessarily the first responders or the people who live in the city at that time, but the people who worked in the city who had to come back to work in that area. I lived in Jersey City. I lived downtown when 9/11 happened. And I remember there was about a day or two later, the breeze was coming into my apartment, and the smell was just horrifying. And I was just thinking I couldn't imagine the people who were living in that area, because it just was so strong and just powerful. And it was just, I can still conjure it in my mind, because it was that potent. So like the people who actually had to function in that area over a long time, I can't imagine.
So the people, when I said the 100,000 in the survivor cohort, that did include people who, quote, worked in the area. What it did not include is people who lived right across from, even though I showed you the map that included Brooklyn on it, and nobody wanted to credit New Jersey people as being exposed, even though we had people in New Jersey who were exposed. So it really only, in terms of who it included for living and working, you had to either live or work downtown somewhere in the area around Broadway. So we don't really know the answer to all that, because it was really hard to measure. Now, I also said gases. Remember, I said the gases. So that's the problem. The gases were not easy to measure. The particles were easy for Dr. Leoy's group to measure. The gases are really more hypotheses that Dr. Leoy and Dr. Georgopoulos hypothesized about, but the particles measurements were real. So we certainly have a lot of people who have some degree of closure, because we could say, well, we don't think you were a bad person and that's why you got your cancer. The other thing that I also glossed over in the presentation is, in terms of our prostate cancer patients, are African-American men, and there are an awful lot of African-American men in both law enforcement and skilled construction that we see here. And you always have the discussion, should you do a PSA? That's the individual discussion. How good a screen is it? If you come here and you're an African-American man, you're going to be talked into doing that screening, because I'm really worried about you. And many of our patients have seen either Dr. Kim or Dr. Jang or Dr. Godespor. We've sent you an awful lot of patients with prostate cancer. And of course, prostate cancer is a common disease, but in our patients, it's way more common. And there's some medical evidence that it is more aggressive when it's found in African American men compared to Caucasian men. Um, and that's been a pretty big deal. You have a lot of our prostates here at CINJ. And
Dr.
bladder,
Grace,
and bladder as well.
I wanted to share with you that when I worked for a previous organization, I ran the pulmonary rehab program, and I had several patients that said they were going to the Rutgers program, and they had been diagnosed with the interstitial lung disease,
Right.
and they actually were lung transplant recipients after the exposure. I had about two, and I had a woman that was all New Jersey residents, but lived or worked in around that area. So it's amazing to see the progress and the lives that were saved with all the work that you're doing to have been able to have these people in the studies. So,
You know, but it really does have the importance of screening. I have one of my lung cancer patients, and he was actually an FBI agent, and this was a couple of years ago. He died waiting for the Keytruda. Remember when Keytruda first came out, you could only get it if they had the PDL1. You couldn't just get it. Now you can just get it, but we were waiting for his PDL to come back, and he died while he was waiting for it to come back.
yeah, yes, I'm very aware of that.
And so we are about fighting to get our people to do their screening. And I have no idea why technology didn't work, but hopefully you guys asked enough questions for the other people who might want to watch this.
Thank you. I just want to say thank you for being here. My name's Ellen, and this is my team, and I love listening to your presentation. I think I could sit here and we could talk probably about this topic for hours. So very near and dear to me as a first responder. So I'm just thankful for all the work that you do, and it's something that we see regularly. So we see the lives that it impacts and the difference it makes with patient care and the system itself. So I just want to say thank you.
My pleasure, and I guess at least we made lemonade out of our lemons with technology.
We did. Thank you. I will absolutely let you know when we get the final recording, and then we're able to send it out to all the participants. But thank you for your patience and for sticking with it today. And I think it'll be great for them to receive. And if they have any questions, I can forward them to you as well, or they want any more information, perhaps you can give out your contact information if you're okay
Sure,
with that.
that's
Or
fine.
if anything like that, we can do that as well. Well, thank you for your time. I appreciate it.
All right, take care.
Thank you.
Bye.
Bye. Thank you.